Thank you very much. I want to thank the organizers for inviting me to come to this very important meeting. This is my first visit to Brazil, and I've been very happy and warmly welcomed here, so thank you very much for inviting me. We're going to talk today about the pearls and pitfalls of imaging and testing recurrent thyroid cancer. This is a very practical talk, which will help you evaluate some of your patients as we follow them over decades after their initial management. I have no disclosures, and we're going to start with a case. A 45-year-old woman is referred after a thyroidectomy for a very small 1.2 centimeter classical papillary carcinoma. There were no invasion. There was a single parathyroidal lymph node that was taken out incidentally during the surgery, which was positive for papillary carcinoma. Very tiny, 0.3 centimeters. So she's an AJCC stage 1, ATA risk very low. Now, I have to say, if she presented to me today, I would not give her radioactive iodine, but she presented to me about 5 years ago, and we did give her a remnant ablation of 50 millicuries. Her post-therapy scan, as you can see here, showed a little bit of thyroid remnant. This is nasopharynx, and this is iodinated proteins in her liver. And basically, the scan was negative for metastatic disease. Her thyroglobulin at that time, which should have raised a little bit of an alarm in my head, was actually unmeasurable using a second-generation thyroglobulin from the Imulite company. The TG antibody was negative, and because she was such a low-risk patient, I actually discharged her to her local endocrinologist, saying, just do an ultrasound in 6 or 12 months, follow thyroglobulins, and I'm sure she'll be fine for the rest of her life. Well, of course not. She had her first pre-op ultrasound at her outside doctor's office at 8 months, and there was a rounded cystic lymph node at level 2, shown here in transverse and in sagittal. And interestingly, radiology says, well, it's cystic, it doesn't really look normal, but it doesn't fit the size criteria for being abnormal. There was also a heterogeneous but thin lymph node in level 3. And the local endocrinologist checked another thyroglobulin. It remained unmeasurable. The thyroglobulin antibody remained unmeasurable, but they knew something wasn't right. So one thing that you have to learn is that ultrasound images are very operator dependent. The interpretation of those images are also operator dependent. And radiology sometimes does not use criteria that if a node is abnormal, if it's smaller than a centimeter in transverse axis, they won't call it as clinically abnormal. So the pearl is you need to learn how to interpret ultrasounds yourself. So we saw this earlier in a talk, and that one of the things you have to see is there is no single characteristic of a lymph node which will tell you that is a malignant lymph node. The sensitivity, the highest, is the absent hilus, that white line in the middle of the lymph node, but it turns out that although 95% of malignant nodes will not have that white line, only 20% of malignant nodes will also have that. So it's a problem that is not very specific. On the other hand, as in our patient, microcalcifications and cystic changes have a specificity of 100%. So the bottom line is if you see a cystic lymph node, certainly with microcalcifications, that's evidence of metastatic thyroid cancer. So before she came to see me, she actually had a number of tests that were all negative. She had a negative recombinant human TSH-stimulated I-123 scan. She had a negative PET-CT scan. Her basal-stimulated TGs were unmeasurable, again with negative thyroglobulin antibodies. And they're saying, how is that possible with this abnormal node? She was then referred to me to say, all right, I don't understand what's wrong with her. Does she have thyroid cancer or does she not have recurrent thyroid cancer? The answer, of course, is do an ultrasound-guided FNA biopsy. And the cytology was very classic for papillary thyroid carcinoma. It did have a BRAF V600E mutation, and the TG from the aspirate diluted in saline was 124. So all perfectly consistent with papillary carcinoma, despite the fact that her serum TG and her whole body scan was negative. So what we learned, this is one of the very first studies, this is actually even before ultrasound became popular, is by Gil Daniels from Mass General, showed that cytology and the TG on FNA washout have about a 90% sensitivity for a malignant lymph node. But if you add them both together, it's nearly 100%. So the hallmark of what we do is when you see an abnormal node, you should do an FNA biopsy, both with cytology, and then measure the thyroglobulin when you rinse the needle in 1 cc of normal saline. So what does that mean? How could it be positive in the lymph node and not positive in a serum? Well, it turns out that antibodies, when you have self-antibodies shown here in pink, it binds up all the thyroglobulin in the blood and basically hides it from the thyroglobulin by IMA assay. So when you measure a blood sample with thyroglobulin antibodies, it almost always reads as 0. Now, if you do a thyroglobulin on an aspirate and you dilute it in saline, you actually dilute out this interaction, allowing for the thyroglobulin to be measured in the assay. So the pro is TGs from needle aspirates, even in the presence of positive serum TG antibodies, is still accurate to diagnose thyroid cancer. Okay, now, this is a problem. This is actually not very well known, that 50% of patients with thyroglobulin antibodies that can interfere with the assay will be unmeasurable on a commercial assay. What does that mean? That means the commercial assay for thyroglobulin antibodies is not very sensitive, and it will miss low levels of antibody that can interfere with the thyroglobulin assay. All that means is that if the situation doesn't make sense, that you have someone who has an abnormal lymph node and their blood thyroglobulin looks low and the thyroglobulin antibody is low, you should think about doing another type of assay. And the assay shown here is the old-fashioned thyroglobulin by radioimmunoassay. So again, when you look at the TG by IMA, our current usual test, if you have autoantibodies, it does not allow you to measure thyroglobulin. On the other hand, the TG by RIA, the old-fashioned, actually measures both the thyroglobulin bound to antibodies and the thyroglobulin that's free. So if you ever have a case where it doesn't quite make sense, you should order a thyroglobulin by radioimmunoassay. I'm just going to add one more thing here, which I actually just found out about in the last couple of months. So if you also have a patient who it doesn't make sense that their levels are off, that you should always ask them if they're taking biotin. So these tests are all strip-viridin binding biotin, and if your patient is taking biotin for their hair or their skin, that will interfere with the assays. Okay. So in this case, we did get a thyroglobulin by radioimmunoassay, and it was measurable at 0.9. The interesting thing is that when Carol Spencer at USC measured her TG antibody, it actually was low at 0.9, but it's above her rank cutoff of the thyroglobulin antibody that can interfere with an assay. So in fact, this patient did have antibodies, even though it wasn't measured on the usual clinical assay. She had a right neck dissection and removed 3 abnormal lymph nodes, and 6 and 12 months afterward, she is disease-free by our criteria. So let's look at a different case, also a problem with thyroglobulin testing. A 65-year-old was actually referred for a third opinion. Over 10 years ago, she had a thyroidectomy for another tiny thyroid cancer, 1.2 centimeters. No nose, no invasion, sort of no nothing. She got 100 millicuries of ablation, because that's what we did way back when. And her post-therapy scan showed no uptake except for remnant. She, again, was an AJCC stage 1, ATA risk very low, except Her thyroglobulin by the Siemens assay was very high, between 8 and 12. That's a significant elevation in thyroglobulin, suggesting there may be even distant disease. So she had a very large workup. She had a negative radioactive iodine whole body scan, she had a negative neck ultrasound, she had a negative CT scan of her neck and chest, and she had a negative PET CT. So this is her whole body scan that was negative. And her second opinion doctor said, well, you should just have a CT of your neck and chest every 6 months for the rest of your life. And the patient said, I'm not doing that, and then asked for a third opinion. So I was the third opinion. And I stepped back and said, you're a stage 1 patient. You're a low-risk patient. Your TGs are stable, but they don't make sense. So I thought there had to have been another interference. And there's a specific interference caused by a human anti-mouse antibody. In this particular case, it actually gives you a falsely high thyroglobulin. So what I did is we ran the regular Siemens Immulite, which was 11, similar to her other doctor's levels. I then actually went to the lab and said, I need some mouse serum. Got some mouse serum, threw it into the assay tube, and it was down to 1. And then we did a whole different assay by a Beckman second-generation assay, and it was unmeasurable, as was the thyroglobulin by radioimmunoassay. So this is an example where, in this case, when you have autoantibodies, it sequesters the thyroglobulin, so it's not counted, and you get 0. When you have the human anti-mouse, the HAMA antibodies, it connects the 2 mouse antibodies and gives you a false positive signal. So in this case, it can cause an inappropriately elevated thyroglobulin despite the fact she had no disease. So the first 2 cases are actually telling you that the thyroglobulin assays are not perfect. So whether you do radioimmunoassay, immunometric, liquid chromatography, they're not perfect. The first case was an example where autoantibodies caused a false negative result for the thyroglobulin done by the immunometric assay, our normal, usual, everyday assay. And patient number 2 had a human anti-mouse interference, which gave you artificially too high thyroglobulin despite having no disease. Okay, let's go on to case 3. This is a 41-year-old who has a syndrome where you get abnormal growth of soft tissue and cyst formation. She had a 2-centimeter papillary carcinoma, but she had some risk factors. She had extensive extrathyroidal extension. She had 13 out of 15 level 6 or central neck nodes. Her post-op thyroglobulin was relatively high at 7.5 with negative antibodies. She's an AJCC stage 1, but an ATA risk intermediate. She was treated with 150 millicuries of radioactive iodine, and this is her scan, anterior and posterior, the whole body scan. She appears to have uptake in the thyroid bed. She seems to have uptake in her skull and uptake in her chest, plus her liver, her hands, and some urine. And the question is she really a stage 4 patient? Well, this is a case where when you get tomographic cuts of the radioactive whole body scan, you confuse it with a CT scan. In this case, this is her CT scan showing a soft tissue mass at this location, which is actually cystic. When you look at the bone window, it's here. When you look at the axial cut of the whole body scan and then fuse them together, you can see that the uptake was in a cystic lesion, therefore not a metastatic area of thyroid cancer. So where else can you get cystic? So wherever you have cyst fluid, radioactive iodine can diffuse in, but if there is a limitation of it diffusing back out, you can get a false positive. I've actually seen renal cysts give you a false positive post-therapy scan, cystic gallbladder disease, bronchogenic cysts. I've seen it in dermoid cysts, just fluid in a ovarian cyst, not with a dermoid tumor, nasoalveolar cyst, and bronchiectasis. So you can have many different reasons to have false positive whole body scans. I'm going to show you just a couple other pictures of cysts. So this is someone with a post-therapy scan. There's an uptake in the thigh, and when they did the MRI with a bright T2 spot, this is a cystic lesion in the subcutaneous tissues of the leg. This is another patient that had on AP, looks like uptake in her head. You can see it on an axial. When you see on the CT scan, you see actually nothing wrong. But when you fuse the CT with the radioactive iodine, you can see that all of the uptake is actually in this patient's hair. So this is a way of also finding a false positive by using a combination with the fusion of the CT scan. Okay, so in this particular case, this uptake was due to that cyst. This was due to her hair. This is just the iodinated proteins from her, thyroid remnant. This is from her sweaty hands, and this is from her urine. So you can have many false positives scans on a whole body scan. There are other cases of false positives that you should know about. This is a patient who had a post-therapy scan and had uptake in her anterior mediastinum plus a little bit of thyroid remnant. When we did her CT scan, you can see this very typical soft, well-demarcated triangular, some people call it sail-shaped mass in the anterior mediastinum, and this is a remnant thymus. We see thymus uptake of radioactive iodine probably in as high as 4 or 5% of patients, especially if they're younger, and people can have persistent thymuses very frequently. But there is a pearl. When patients have recurrent thyroid cancer, recurrence after their initial therapy, radioactive iodine whole body scans are not very good at detecting it. And it may be we've already treated the patient with the radioactive iodine for ablation, and therefore whatever residual tumor is left behind is not very iodine avid. But this is a study by Klus and Mazzaferri from 2005, and they looked at I-131 visualization in patients with recurrent disease. And what they found was, 20% of patients had a little bit of uptake in their bed, not representing the actual metastatic disease. And then the vast majority of people had no uptake at all. So their quote is, a diagnostic scan failed to identify tumor in any patient with recurrent metastatic disease. So generally, once I have a negative whole body scan and someone's thyroglobulin starts rising, I generally don't repeat a whole body scan because it is virtually never positive. Let's go on to case number 4. This is a 42-year-old woman. She had a thyroidectomy again for another small cancer, 1.5 centimeters. She had extensive lymphovascular invasion, extrathyroid extension, and she had 2 metastatic lymph nodes, one in the central neck and actually one in the level 2, which is the lateral neck. Because of her age, she's AJCC stage 1, but she's an ATA risk intermediate for recurrence. She had a moderate dose of radioactive iodine, 50 millicuries, and a whole body scan that showed only remnant. Her thyroglobulin, at the time of the treatment was low, with a TG of less than 0.9 and antibodies that were negative. Because of that unmeasurable TG, I learned from the first case, we actually got a radioimmunoassay on her, and it was very low still, though, at 0.9 with a very low positive antibodies. She then got lost to follow-up for 5 years. And she came back, her TG-RIA was really no different at 1. Her antibody levels were 3, which may be slightly higher, but not significantly. And I have to say, I probably wouldn't have done this, but my colleague ordered a PET CT scan. So she got a PET CT scan. This is an axial view, and you see a focal area of uptake in a level 2 lymph node. Now, the SUV was relatively low. It's only 2.6. And she was then referred to me to say, can you please help me find this lymph node and prove that she has metastatic disease? So when I did her ultrasound, she actually had 2 abnormal lymph nodes, or 2 suspicious lymph nodes. She had a left level 2 that was about 2.8 centimeters with a sort of funny star-shaped hilum. There was not cystic, there were no microcalcifications, there was no peripheral vascularity, but it was sort of funny looking. It was one of the funny looking nodes. But she also had a rounded, very hypoechoic nodule node in level 3 that I thought looked a little suspicious, maybe with peripheral vascularity. So we compared her her PET scan with her ultrasound, decided that this star-shaped hilar lymph node, 10 minutes, was actually was the node that took up was hypermetabolic. And we biopsied it with ultrasound guidance and got mature lymphocytes, and the thyroglobulin was less than 2. So the take-home lesson is that we frequently see hypermetabolic nodes in level 2 of the neck, under the jaw. These are mostly reactive lymph nodes, and in the cases of reactive lymph nodes, the SUVs are usually lower than 2.8. So this is common to find this low-level PET activity in these nodes. What about the other node? So when this node was, we did it biopsy in the level 3, and the interesting thing was that when I did the biopsy, the patient jumped off the table, virtually said, this is the worst pain I've ever had in my life. And so we said, all right, and so I did my second pass, and I actually watched my needle, and as soon as it touched the surface of this thing, she jumped again. I backed the needle out, and she said, oh, no pain. Backed the needle back in. She said, this is the worst pain of my life, so we stopped. The TG was unmeasurable. The cytology was insufficient because I only got one needle into it. But this is not a lymph node. This is a traumatic neuroma. So it occurs in patients who have had lateral neck dissections. And the hallmark is that when you put a needle in this thing, they get a knife-like pain in their neck. So there's been a couple of studies looking at traumatic neuromas. They virtually never happen with central neck dissections, only happens with lateral neck dissections, and never occur medial to the jugular vein. So in this case, when you're looking with ultrasound, the transducer's in the transverse plane. In the upper neck, it's going to be behind the sternocleidomastoid muscle in level 2 and 3. And then in the lower neck, it usually is lateral in level 5. If you turn the probe so that it's higher towards the midline, you can actually sometimes see the branches of the cervical plexus going into the mass itself. Generally, they're fusiform. They have ill-defined margins. They're mixed exogenicity. They generally don't have vascular flow in there, but they can have these little hyperechoic lines inside. So this is a caveat that if you put a needle into a lateral node and the patient jumps, then it's most likely a neuroma. So not all rounded nodes, masses in the neck, are metastatic nodes. Rounded reactive nodes are common in level 2 and can be low-level PET positive. And the pro is that there are many other normal structures that you can see on ultrasound. So I'm just going to go through a couple sort of interesting ones. This is a woman who had thyroid cancer, and she had a level 6 mass. TSH was low, thyroglobulin was 1.7, and here's the mass. The interesting thing is that when you did the Doppler, it had a polar feeding vessel with arborization. That's the hallmark of a parathyroid adenoma. So when the biopsy was done, we did an aspirate washout for PTH, which was elevated at 86, and the thyroglobulin was unmeasurable. So we actually, in this woman, found a parathyroid adenoma, not a metastatic lymph node. This is another patient who had this hyperechoic mass in level 6. We couldn't see the esophagus, but it was too anterior to be a normal esophagus. And so when she swallowed, it did move. So just to see what it was, we did a barium swallow, and she had a Zenker's diverticulum, so outpouching from the esophagus that you can see in the thyroid bed. The final one is one that actually worries me the most, because I've seen 2 or 3 of these over the years, and I have to say, I've always missed it. So this is someone who has a mass low in level 6 next to the trachea. And when you look at it, it's hypoechoic. It has wall-to-wall little hyperechoic, non-shadowing foci, which could be microcalcifications. But in fact, what it is a cervical thymus. So you have to think about it. Usually when I see it, I end up doing a CT scan to prove it, because when you look at these, they make me very worried about metastatic papillary carcinoma because of the hyperechoic foci. But the hallmark is that there are too many of them. It's just really packed wall to wall with these fine echoes. Okay, so in terms of long-term follow-up with thyroid cancer patients, there are a lot of things that cause false negatives and false positives, and whatever modality we use, whether it's thyroglobulin assays, ultrasounds, radioactive iodine whole body scans, and PET scans in those patients who are iodine unavid, there are situations when you have false positives and false negatives, and what you have to really do is think about every patient. And my next talk is going to be talking about risk assessment, and that's where it's important to understand that you have to risk assess a patient every time you see them in clinic, use your judgments, and then you really have to have patience to look at the studies yourself. I tell my fellows that the most important thing you're going to learn from me is that you have to take that extra 5 minutes to look at the images yourself, because there's nothing that's better than your judgment. Thank you very much for your attention.